Welcome to Dying in Grace, the program designed to educate us about healthy aging and all aspects of end of life so that we can become more comfortable and knowledgeable about the topic for ourselves and for our loved ones. Each week, I invite a guest who has a special expertise or a unique perspective or story to share with us so that we can all learn from the rich community resources here in Santa Barbara. And this week, I am delighted to welcome my guest, Rebecca Goodman, who is a neuropsychologist.
That's right.
So let's start with, what is a neuropsychologist?
So a neuropsychologist has a Ph.D. in clinical psychology. In our specialty of neuropsychology, we're interested in the relationship between the brain and behavior, and also the brain and cognition, information processing. Some of us do research, but I see real people.
So going into psychology, how did you choose that and choose seeing people versus the research side?
Okay. So first of all, let me say that when I was in high school and college, I was a nurse's assistant, a CNA, at a facility and did home health care. So when I was that age, I was helping people into the bathroom and getting dressed and such. But when I was in junior high, I actually wanted to become a neuroscientist, and I wanted to study the biological basis of thought. That really was my goal. So I went into school to get an academic degree, and which would have been a good career for me, but I found that in part of this program I had to deal with real people. I had to go meet people who may have had brain disorders, meet them, talk with them, and do evaluations of them. And I love those days when I got up and it was a practicum day and I enjoyed the work, so I decided to take a clinical route.
Wow, well, it sounds like you have a natural aptitude to interact with people. I mean, from your early experience of wanting to help people, and also seeing people in kind of fragile states. When you're a CNA, people are really relying on others. So it seems like that's a unique calling to really meet the people and not just do the academic or the book side or the research side.
It's true, and actually I think the best thing about that job for me when I was a nurse's aide, still one of my best jobs, even many years ago, was being with people in daily life. It's not just in the office. It's, what's it like when they need to get a glass of water and they can't reach it? What happens if they're alone and their family doesn't visit them for a week? So I think it was really helpful for me to be exposed to the range of experiences of those people having those day-to-day life events.
Well, yeah, and that was a really tender age. I mean,
that's
a great awareness. I mean, I think of teenagers today, and I don't even know whether they let teenagers be CNAs quite yet. But I mean, that kind of sensitivity, because it's a pretty you see the whole range of emotions. And one thing I know is true is that most people in nursing homes do not have any visitors whatsoever, and a lot of them don't even have family at all.
That was true when I was working. That's right.
Yeah, so that's still so you went into the field.
Yes.
and now you work here in Santa Barbara, and you have your own office, right?
I do.
So you don't work with the hospital or anything. You're an independent person. Is that accurate?
Yes and no. So first of all, my career did start in hospitals. During my training, I was at hospitals in Chicago and before I came here, and in Nashville, where I went to school. And it's true that I have my own office. However, I really regularly interact with various people who are working on the cases that I'm working on. So, that's how I met you, right? So, there's a network of people who work in different places, who work with each other regularly. It's kind of having a team without walls at some level. So I get referrals from mostly neurologists, but other doctors. I get referrals from attorneys who are asking me to assess whether someone has decision-making capacity, or from personal injury attorneys sometimes to see if someone had an accident and to quantify whether they had injuries. So, and I get referrals from Adult Protective Services.
Okay, so those are the outer agencies. So, and just to clarify for the audience, I used to work for the Alzheimer's Association, and so we would refer family members who were concerned about where is dad or my husband or my mother or whatever, what is their ability. And so when someone gets a neurological assessment, when they go do that, or you go to them and do it, maybe you do both, you go to where they are, or they come to
I
your
make
office.
house calls too.
You make house calls, okay. So if I was observing you doing a neurological assessment, what does that look like, and how long does it take?
Okay, so first of all, there are neurologists who have MDs, and then neuropsychologists. We're different, so just
yeah, right.
So there are several parts to our assessment, or to the assessment I do in the office. It's two main things. I'm interviewing the person to get their history, or even see if they understand their history, and to make observations about their ability to interact, for example, or communicate. And then I give standardized cognitive tests, like memory tests and math and verbal and visuospatial and mood tests.
What was that last thing?
Mood tests of
mood
depression,
test.
anxiety,
Okay,
and such.
no, I just, yeah.
Yeah, and the standardized test is the one thing that's most unique to neuropsychology. The standardized test, so people will be home and say, well, I've lost my keys 3 times today. Is that abnormal or not? How do you know? We give you standardized tests that have been given to a gazillion people at different ages, and I'm able to compare their performance on these tests to people their age to see if they're performing outside of normal limits or within normal limits. So what you would see is the interview, you'd see me watching the person, you'd see me giving tests, you'd see me offer tea and coffee, try to make it easy and comfortable, and then after that, in most cases, only if it's okay with the person I'm evaluating, I'll ask a family member, what changes did you see in this person? When did you see them? So I do that interview sometimes on the phone. For some cases, I also review medical records.
So do the people that you're talking about, do they self-refer, like, oh, I'm not sure something's going on, or is it more frequently that a family member saying, hey, we've got to get mom evaluated? What do you see, or you see a combination of both?
I see a combination of that, but if someone thinks that they might have a dementia or some kind of change in behavior, if they come directly to me, I'll say, I'll see you, but you got to see a doctor first. So if someone has new changes or possible changes in their thinking or behavior, an important step is to rule out any reversible medical causes or non-reversible as well. So it would always be with a doctor.
Right, and yeah. I know from my days at Alzheimer's that could be medication. You take a new medication, it's interacting with something. It could be dehydration, you haven't been drinking enough, so you're losing some of your cognitive skills that way.
Right.
There's ruling out everything else before we go for the brain thing.
Exactly.
So, yeah,
right.
Yeah, so yeah, that was always our approach too. So I go to the doctor. They can't see anything, according to them, everything seems fine. So then what kinds of things do you discover? Like when you do my brain testing, can you give me a diagnosis? Or you just kind of say, here's what I've discovered?
Yeah, so usually a diagnosis is made by a doctor, and so for those cases where I'm seeing if someone might have a new brain disorder, there's a lot of different kind of brain disorders that can affect your cognition. So if they were to go to a neurologist, the neurologist may or may not give them a brain scan. It's not necessary for everybody. They may do blood tests to look at those reversible things. They may look at their motor function. Do they have a tremor? Is there a problem with their walk? Is there something with their reflexes? And then they go to my test to see if someone has cognitive deficits outside of expected for normal aging. And then I look at some other things. Do they have other behavior symptoms that may indicate a certain brain disorder, like certain kinds of hallucinations, for example, that are new. I might also look at depression to see if either they have a brain disorder that causes depression, or maybe they feel like they're forgetful, but really they're depressed. And it's really within normal limits for their age. So all this information gets put together. I don't make a diagnosis because I don't read brain scans, et cetera. I give it back to the doctor. In my report, I'll say, well, it's consistent with this, not consistent with that. It's in a gray area. Let's get a baseline set of scores and do it again. But a good detective gets a range of evidence and puts it together, and usually the doctor makes a diagnosis. But my scores are part of it. For some people, for some cases, depending on the issue, the scores that I have are the key thing to make a diagnosis. For other people, they knew otherwise.
It's just a confirmation.
Right.
No? Yeah, or it just confirms what they suspected.
Right. And I'm not just helping with a diagnosis. I mean, the way I feel I'm most helpful is to make recommendations about safety and quality of life for people who really are impaired. You know, you have a diagnosis and it's a doctor's job to say, well, give them this medicine or this vitamin, or let's cut down on this medicine with side effects. But I have families who say to me, what do I do? You know, my dad forgets to take his medicine. What do I do to keep him safe? Or, you know, I have a relative who's very anxious all the time and has delusions. What do I do? So I make practical recommendations. I give out a lot of website links, like read about this, read about that, and referral to community resources.
So most of your clients, are they mostly like over 65, or do you see a whole range of people? I know you said some might be out of accidents, but is the majority of the people you see over 60?
So there are clinical neuropsychologists, clinical as opposed to research, who see the full range. So there are pediatric neuropsychologists. That's not my thing. I just am not equipped or trained to see kids. I will see people age 18 or over, but my main specialty is older adults. But you know, it's maybe 70%, 80% of my practice. I see younger people who have accidents. Younger people can have strokes, alcoholism. There's some brain diseases that start younger, unfortunately.
So the recommendations you give families are mostly other community resources. So when they say, what do I do? You're saying, well, you might want to check out Jody House, or you might want to, you know, some of the things that exist in this community, or like you said, learn a little bit more about X, you know.
So I do give like a list of resources, and I'm really individualized. It really depends on the person. I end up doing a lot of coaching on things like, what do I do if my relative is irritable and yelling at me all the time? You know, should I yell back at them? Or what do I do if my relative thinks that, you know, the neighbor is stealing the jewelry from me? Should I tell them it's not true? What do I do? And so I coach them on the best ways to settle the situation down, to calm it down.
So you're doing caregiver support.
Yeah, support and just coaching and new concepts about how to deal with someone who's being unsafe or unhappy. That's a lot of family coaching.
So do you follow the patients through a long period, or that you do the assessment, you give them some initial next steps that they could do, some suggestions, and then is it a new patient, or do you follow your folks, or how does that work for you?
Yeah, I mean, I usually do just one-time assessments, and there are some neuropsychologists who also do therapy. I just don't. I'm full up with the assessments. And the only time I see people a second time is when, first of all, I'll see someone and then I'll have a feedback session if they want it. Some people say, I don't want to know what's wrong with me. The doctor told me to do this. Send them the report. I don't want to hear it. That's fine.
Do you get a lot of that where people are in strong denial? They're afraid they're going to find out that they have Alzheimer's or something? Or?
The whole range of things. My kids are making me do this, you know, that kind of thing. I don't mean to.
Yeah.
I understand it. So, but I'll have a feedback session either on the phone or in person with the person I evaluate and or their families. I'll send something written if it's helpful. And I usually don't see them again because there's usually not a purpose in it. The times I do is to see if there's change. So sometimes people come in and they're fine. You know, it's normal aging, or they were worried or whatever. And then I'll see them again in a few years to see if their scores have changed from their baseline. But it's not a regular routine for me to follow up.
So it's kind of a one-time. So you're constantly getting new people in. So you might
all the time.
So when you think about the range of people that you've seen, is there a particular story that sits with you, or, you know, I mean, you have so many, but is there somebody that was particularly hard or was particularly important, or something that you remember, it sticks in your head?
Boy, That's hard to narrow down. So the ones I'm not going to describe are where people who've been abused financially or exploited, who've been tricked by people and scammed by people. These are common situations, and I will do an evaluation of people to see if they had capacity to give all their money away to someone, or to be taken to Las Vegas to get married and change their will. Those are cases that are interesting. But the situation I think that's most important is the following: is, again, most people who get brain conditions don't get paranoid. But some people do, and there's things we can do about it. So to me, the most important coaching bit that I get is the following. If somebody says, where's my jewelry? My neighbor must be stealing my jewelry. I know they did it. The natural thing for family to do is say, oh, Mom, there you go again. You're wrong. Look, your jewelry's here. It makes no sense. The doors are locked, and they try to debate the person. But even though it seems like respectful to give information and reason with someone like that, it can make the person, it can just escalate the battle. They believe it despite the evidence anyway.
Right.
And the most important thing I think to do in those cases, I don't recommend lying, but you can, is to respond to the emotion as opposed to the content of the belief. So the emotion, if someone's feeling like they're being robbed, is often anger, but it's also fear. So I recommend just you keep the climate calm, and say, look, I'm sorry, I don't know. I don't think that your things were stolen, but we're safe. It's okay. I've got your stuff. I've got it all taken care of. Be calm, be reassuring. If there's a good time, transition into distracting something, make a joke if it's not as long as it's not mocking. This is true of us too. You don't have to have a brain disorder. I mean, if someone is debating you and says you're wrong, you don't respond as well as if someone just comes in with a calm attitude.
Well, I think under most arguments is the emotional content.
Right.
That's the skill of listening for what's underneath what's coming out of the mouth. And I think a lot of us have lost that ability to listen to each other. I mean, certainly we see there's no discourse anymore. People just want to be right. And it's very challenging. I think in particular, when there's familial relationships, like you said, mother-daughter or husband-wife, those are kind of the common things. So I would think, but I'm not sure, is it challenging for family members to get their loved one to take the test, to see you, or is there a lot of pushback to even get them through the door?
So the answer to so many questions about this is it really varies. Depends. And there's a full range. There's some people who are really eager to know. There's some people who are indifferent and are just sort of going with the program. And when people are resistant to come, one thing to do is to ask why, and you might learn something from it. But the other thing again is to answer somebody's questions in a way that's calm. And if someone says, I don't want to talk to you, I'll say, okay. Well, actually, I start with, can you tell me why? Is there anything I need to know? Can I explain how this goes? To try to make them comfortable. But I'm not going to try to force anybody or trick anybody to do it. But, so say families,
well, that's
what do
out
I
of
do?
Integrity. I mean,
But
I understand
why
you have the tea and coffee or whatever, the hostessing to kind of relax people in.
Absolutely. But when families say, what do I do because my relative, doesn't want to come, I might ask, why do you think they don't want to come? But I'll also say, I wouldn't over-explain it, so because I wouldn't say, there's something wrong with you and we got to figure it out and prove it to you. You say, the doctor says it's a good idea. We want to learn more. This is what I've heard about the process, and don't need to over-explain.
Well, I had a colleague that I was telling her that she should get her dad to get evaluated because there was some unique behavior that was coming up. It was out of the blue, never had it before. I said the same stuff. When was the last time we went to a doctor? Like, is there new medication? Kind of doing what little I know. And I said, it sounds like he needs, since his behavior, and he was doing exactly what you say, some of that paranoid stuff, people are stealing my things. And then it kind of went away. But every time she talked to him, it was like, I don't need that, I'm not doing it, I don't believe in doctors. And she's like, well, what do I do? And I was like, there's nothing you can do, I don't think. And, so it gets challenging sometimes. People get really obstinate about, you kind of as the loving family members say something's really wrong, but you at the same time you don't want to be so disrespectful that you force, because they're not going to cooperate anyway.
Right. And one other thing about that is if you're having that trouble, there's a lot online about strategies for how to manage difficult situations and behaviors and safety. So for example, if you were to go and Google dementia resistance to care, or parent or caregiving and agitation, you'll get a lot of hits. And some of the hits are really useful. So I recommend that.
Yeah. So you mentioned that you work with APS, and so when do they call you in? Is it the financial elder abuse mostly, or are there other times that they bring you in?
Right. So Adult Protective Services sees cases of people who are potential victims of physical and sexual abuse. I'm not usually called in for those, and I'm not exactly sure why. It's usually for financial abuse or self-neglect. And they don't send all of their cases to me because they're able to proceed without the kind of information I have. But sometimes they just want to, they got a call from someone who lives alone, and the neighbors think that they're neglecting themselves, and they just say, this person's new to us, we have no information about them, they've never seen a doctor, please see the person and tell us what we need to know about her. And other times, if there is possible legal action to be considered, like a conservatorship, or did this person have capacity to change their will, they will look for my opinion to see whether or not the person did have capacity to make a decision, or whether the person requires conservatorship given mental limitations. And my job is, I trying to strike a balance between, if someone's independent, you want them to, if someone's capable, you want them to maintain their autonomy. If someone's vulnerable, you want them to be protected.
Right.
So sometimes the evaluation actually, I think the evaluation is more truth, and it's protective for everybody. And
do you go to the homes, like for somebody like that, when APS calls you, you do a cold call and make an arrangement? How does that work?
Never cold. I do make house calls because,
Okay. It's interesting too, because I think people that live alone sometimes, when they know someone's coming, they'll rally all they'll muster their strength. I've seen that with couples sometimes too, where the kids are coming for Thanksgiving, so they do everything they can to, and they're exhausted afterwards.
Right,
they're covering or really trying to remember or put on a good show, if you will.
Right, that's true.
Yeah. So you mentioned conservatorship. Could you just, for our viewers that might not know what that means, could you kind of talk? So you find somebody who lives by themselves, has no loved ones nearby or no one around, and can't care for themselves or can't make decisions. Or when does a conservator step in?
So I'm not a lawyer.
Right.
I want to make that clear. So that's something that a lawyer would decide and do the paperwork on. But and it varies a lot by state. But the questions that I answer when there's a question about conservatorship are: is the person able to provide for their own basic needs like food, clothing, and shelter? And of course, I can only do the mental stuff. I'm not trained to do some other tasks, some other evaluations. And also, is a person vulnerable to undue influence? It's not something you have to evaluate for every case, but it's for some cases. So I gather the information that I have, try to get a history, to try to talk to somebody else, and put my findings together to see if they meet either of those two legal criteria. And I show my work. Wow. And the other thing is, ideally, before someone is conserved, the first thing to try to do is to see if you can restore, you want to avoid taking someone's decision-making power away, right?
Exactly. You want to give people as much independence as they have the capacity for.
Right. So I might say something like they can't manage their finances, but they can manage their medicine, or vice versa, to try to make, to try to guide other people if they want to have limited help for the person. And also, is there anything you can do to improve their ability? What if you just give them hearing aids or glasses or meals on wheels? Is there anything you can do to make them safe in their home, etc.? So we try to maximize, again, autonomy and protect safety.
Yeah. It's interesting too, there is such a high incidence of elder abuse, and particularly the financial scamming abuse and the telephone, this whole thing with robocalls coming forward, and how people actually target people who are lonely, people who are older, and someone was telling me just the other day, she had to stop her mother from sending some person on the phone, $500 to whatever his sad story was. And it was someone that was clearly a predator who had just kept calling her and befriending her and, checking in. And I think it really speaks to, in a way, how we neglect our elders, and so we create a space for predators to get in a much easier way, because people are isolated and people don't know their neighbors necessarily, or feel like they have the time to look in or take in,
That's true. And, elder abuse is by stranger predators is so pervasive, it's unbelievable. But older adult children commonly also financially abuse their parents.
Yeah, I know. Well, Rebecca, we're going to have to leave it here, but thank you so much for such an informative discussion. I really appreciate it.
Good.
And I would like to thank TVSB and my crew, Elliot Jacobson and Michael Nicholson, for their support. Thank you, the viewer. If you'd like to see past episodes of Dying in Grace, you can go to dyingingrace.com or YouTube Dying in Grace. And Rebecca, I want to thank you again, and I'd like you to sign in our Book of Living Love. Just put the name of someone you care about who is no longer with us.
Okay.
Because
I will
to
do
live
that.
in hearts we leave behind is not to die. And thank you again so much for being part of our show.
Thank you,
It's
Arlene.
great.
Yeah.